Thank you, Anna. It's a pleasure to be back. This is day 3, my 4th or 5th talk at the meeting. How many of you are oculoplastic surgeons? There's none? There's one there. Great. So then I'll try to do justice, because if not, I can cut down a whole lot of stuff in just interest of time. So I've been asked to share how is practice of oculoplastic surgery different in our part of the world, which is Southeast Asia, which is a nice heterogeneous mix of South Asians, Southeast Asians, and East Asians. So I'm going to share some anatomical and surgical perspectives. Even though they've given me 15 minutes, I'll have to rush through things itself. So when you talk about East Asians, the standard thing they talk about is the double eyelid East Asian blepharoplasty. In the West, they used to call it Asian blepharoplasty, but Asians is a heterogeneous population extending eastward all the way from Istanbul on one end to Japan and Korea on the other end itself. So it's now East Asian, which is very different from South Asian, which is very different from the West Asian. But in the West, they still use the word Asian blepharoplasties for these patients. And you can see that there are distinctly obvious anatomical differences, as you can see in the various ethnic groups. These are my conflicts of interest, but not really nothing to do with the presentation itself. So when you look at the common surgeries that we do eyelid surgeries, lacrimal surgeries, orbital surgeries, and we are now not just ophthalmologists, we are not just oculoplastic surgeons. Our society is even called oculofacial society. We now look at the whole face as a whole. Thyroid eye disease is no longer a thyroid eye disease, it's an orbitofacial disease. So just so you know, we look at the whole face as such. And that's the world population. You can see obviously where the population is concentrated. South Asia, predominantly dominated by India, which has now overtaken China, and China is the other one. So these are two powerhouses for population growth, for the same time for diseases, and with economy getting better, longevity. So we're dealing with a lot of pathology now in the growing elderly population itself. And again is a population distribution both by nationality and ethnicity. So South Asian anatomy is very different from the East Asian anatomy. So what's the big difference? Number one, first we have to be aware that there are ethnic variations. Today we live in a globalized world. There's everybody born from anywhere at this point of time. There's no guarantee 20 years later they're going to live in the same place. Global migrations is happening. In the east and northeast of India, we now know the East Asian anatomy and pathology coming in. I'll touch a little bit about it. And with medical tourism, people are traveling to centers of excellence. So nothing prevents a patient from one corner of the world going to other corners of the world. We have patients coming all the way from Russia for retinoblastoma management and stuff like that. So it's very important that all of us are aware of the various variations. The first and most important thing is eyelids. So East Asian blepharoplasties used to be called colloquially as double eyelid surgeries. And that's based on the pretext that the anatomy is completely different. You can see there's an absence of the lid crease. You can see the pre-epineuritic fat is not just pre-epineuritic fat, but comes all the way to the pre-tarsal area as well. This lack of adhesions, so on and so forth. In addition to that, there's epicanthal folds, premature brow ptosis, lateral hooding, and so on and so forth. And we do surgeries, various forms of techniques, and we find anatomy. For example, if you look at the bottom right, a standard anatomy textbook will say there's an upper medial fat pad, there's a central fat pad. But in our East Asians, we even find lateral fat pads. That's where textbook anatomy that we read written from the West or anywhere else may not always apply towards the East. These are common eyelid conditions you see in children, developmental conditions such as epiblepharon, and as they become young adults, you can start seeing, looks like bilateral ptosis is nothing but a lack of support to the lid in the form of a lid crease, causing a pseudotosis. And of course, elderly patients, you can see the lady on the right, where you can see severe brow ptosis, asymmetric brow elevation, dermatochalasis, ptosis, upper lid skin literally touching the cheek, and that's kind of patients we deal with. So you have to be aware that there's an entity called epiblepharon. It is the most common pediatric oculoplastic surgery that we do, and this is a developmental condition. It's not an abnormality. If you read a Western textbook, they call it an abnormality fold, but this is a developmental, racial, ethnic condition. And unless you stain them with fluorescein, we use 2% minims for our patients, you will miss this kind of keratopathy, and you wonder why these children are constantly blinking all the time, why they tear, they have photophobia. It's because of keratopathy, which oftentimes is diagnosed as chronic allergic conjunctivitis and so on and so forth. So these are examples of patients where we've done both an upper and lower lid epiblepharon correction. Yes, we do all functional surgery with an aesthetic touch. So to us, we are now not only getting rid of the lashes rubbing the eye, we're giving them a pretarsal fold, eyes are appearing bigger, and the child also has a better self-esteem. So what about aesthetics? We don't stop just with the upper and lower eyelids. We talk to the brows as well. Of course, brows, people express themselves variably, but we are talking about normal brows. In East Asians, and if you look at them, sometimes they have very sparse eyebrows. And if you look at the forehead in any patient, and oftentimes ophthalmologists and ophthalmology residents and fellows only look at the eyelid, upper eyelid, lower eyelid, and that's about it. We ask them to look at the hairline and the forehead. Tells you how much effort they're putting in to try to treat the lash ptosis that they have with frontalis overaction. For the same reason, a lot of these patients have premature brow ptosis. So in our practice, brow lift becomes a significant part of our practice, which I don't see much happening in South Asian continent over here. So these are again patients who have had upper lid epiblepharon with ptosis or pseudotosis, where again upper lid blepharoplasty gives you good results. So coming to the brows, this is an unaddressed aspect of the oculofacial aging changes, gravitational changes, and of course it runs in families as well. The ink mark that you see on the forehead is literally where the orbital rim is. It tells you how far down below the brows have descended. And these are patients where you will not be doing a blepharoplasty or a ptosis. These are patients who will deserving a brow lift first, and then only then you do an upper lid blepharoplasty. These are examples of patients where we do a direct brow lift. Notice how sparse eyebrows. Yes, there's a little bit of scar, as you can see on the side, but if you construct your wound very well and the patient heals well, scar is very minimum. So in our books, this is a very underperformed procedure in aging changes of the face itself. And this is an example of a staged rejuvenation of this patient. We're not making her look like Taylor Swift or something like that. This is like her making look better, younger, and more functional in society. So first stage was a coronal brow lift. After doing a coronal brow lift and stabilizing the brow, look at the forehead in the central picture, we've raised and stabilized, and then we go do a stage upper lid ptosis and blepharoplasties. The main complaint from the family was they could not keep this old lady at home anymore. She became so active that they could not keep her at home. So just to let you know how we can be serving our patients even better. And of course, in younger patients, we do endoscopic brow lifts. So quickly shifting gears to lacrimal surgery. How is it different? DCRs is quite popular. I know in India, they do a lot of lacrimal irrigation prior to cataract surgery, glaucoma surgery. That is the only way they usually pick up unless the patients have an acute or chronic dactyl cystitis. In the past, the standard treatment was either an external DCR, but in our now what is really coming in a big way is endoscopic DCR. That's now the procedure of choice for most patients with NLD obstructions. But what is really new is endoluminal lacrimal duct recanalization. I did a keynote yesterday on dacryoendoscopy and ELDRs for these patients. Why is that important? East Asian patients have a far thicker maxilla. So if you, I don't know how many of you are from Calcutta here, Tripura, Mizoram, anybody, Arunachal Pradesh. When you see these patients, these people have a very thick bone, especially the younger patients, and dealing with the bone becomes very, very challenging. Putting a scar in the medial canthus becomes very difficult as well. They have a high nasal septum. They have a high sac in a lot of patients. Sometimes the patients are not fit for general anesthesia. So that's where, to deal with the big bone, you have to do various forms of instrumentation. I don't know if this video will work over here. So we either need powered instruments, and these are disposable instruments, cost $500 a pop for these patients, and that alone becomes far more expensive. Or if you don't have that, that's the skull base. You can see the metal hitting the bone. That's how thick these bones are for these patients when you're doing DCRs for these patients. So what that led us to is to developing microendoscopes and dacryoendoscopes in our practice, where we are now getting through 1 millimeter endoscopes through the lacrimal system, going down to the lower end of the nasolacrimal duct, and we are able to identify the level of obstruction, identify pathology intraluminally, and they are able to recanalize them. So if you're not oculoplastic surgeons, this may be the first time you're seeing the lumen of the lacrimal drainage system, all with these semi-flexible and flexible microendoscopes, which we use right now in the operating theater, and soon enough we're going to be offering in our office procedure as well. This is an award-winning video. Can you reduce the volume, please? How we do the ELDR. So this is being done in general anesthesia for recording purposes. Basically, we identify the upper and proximal system. This is the 3-port microendoscope that we introduce. After the, if you're doing it in the clinic, we do endoluminal anesthesia. We're actually passing down, and you can see this animation. As you walk down the canalicus, proximal and distal canalicus into the lacrimal sac, you are now seeing endoluminal anatomy, which in the past was a blind area, and we were managing all the NLD obstructions without really knowing what is inside the lacrimal drainage system. So once you recanalize, I use Tramson alone, and then you follow it up with either balloon dacryoplasty alone or with bicanalicular Crawford intubation system. So much so that we are now, with patient acceptance and education, we are able to offer this as an outpatient procedure for our patients. No regional infiltration. We use what is called endoluminal anesthesia, dilute local anesthetic into the lumen. The advantages are manifold, including patient acceptance. You don't have to deal with the bone. You don't have to do general anesthesia. You don't have to do local anesthesia, and you get fairly good outcomes. So much so that ELDRs have far surpassed the external DCR rates in our population itself. So last 2 minutes on orbital considerations. How is orbital anatomy different? The volume of E-stations is different. The lateral orbital rim is different. That's the reason why our Hertel's reading or Moritz reading is far lower than the Asian or the Caucasian population itself. And the deep lateral wall anatomy is also very different. By default, one of the most common orbital surgeries, at least here I would say, is thyroid eye disease with orbital decompression. Thankfully, the awareness of thyroid eye disease is becoming more and more aware. Even if you're not the oculoplastic surgeon, orbital surgeon, but if you're just an ophthalmologist, at least find out who manages thyroid eye disease better. But both in developed and developing nations, fractures are also a significant part of it as well. Now, these are the various surgical landmarks as well, they can see over here, but there are distinct anatomical variations in the aperture, the rims, the volume, and the so forth, and that also affects the nasal cavity. And why is nasal cavity important? A lot of endoscopic surgeries are evolving towards transnasal endoscopic medial wall decompression, so on and so forth. In the interest of time, I'll just move on, but just to let you know, South Asians and East Asians are different. The anterior lateral rim is very different. The lateral wall trigone is very different patients. Orbits are far tighter. If you are giving peribulbar anesthesia 6, 10 cc's, you can still get away with it. In our patients, I don't know, Victor, you know or not, you put 1 to 2 cc in an East Asian orbit, the orbit becomes rock hard. That tells you how tight the orbit and the orbital septum and so on and so forth. So in summary, what I tried to cover in the past 10 minutes or so was East Asian anatomy is different from a South Asian anatomy. So if you're the versatile surgeon, I believe in training residents who can be transplanted to any continent in the world and they should be able to pick up and run. Whereas if you say, I'm only familiar with this anatomy and I cannot deal with the other anatomy, I believe that we are all unprepared surgeons. Those of you dealing with patients from the northeast of India, and you know people from northeast now are migrating southwards. I go to Chennai and I see what people from there. So no longer can a surgeon say, I don't know how to deal with the East Asian anatomy. Be aware of the ethnic variations and offer customized management. With that, I'll put in a spiel for our next exclusive, dedicated 3-day exclusive orbital symposium, full with cadaveric dissection, deferred life surgery, and so on and so forth. And I welcome you all to Singapore. Thank you very much.
I think, is there any pressing questions from the floor? If not, we're 5 minutes late, so I don't want to put the other session later. But if there's questions, we'll be staying back and we'll be able to take them offline. Thank you very much for your attendance today. And thank you very much for the invite from the All India Ophthalmology Society to our Singapore Society of Ophthalmology, and we hope to do more collaborative meetings together.
Maybe I know. Okay, one last question.
One more question? Yes?
You was talking about endoluminal anesthesia.
Yeah.
Can you please elaborate on it?
So traditionally, medial canthal procedure, lacrimal procedures, you need to give the anterior ethmoidal block, you had to give the infratrochlear block, and so on and so forth. But where is the pain really coming from? From the lumen of the nasolacrimal duct. So we use a dilute local anesthetic, the dental cartridge, which is lidocaine with adrenaline. We dilute it 50-50 with saline, normal saline. So the 1% becomes 0.5%. So when you're doing your diagnostic irrigation through the upper punctum or the lower punctum, you just put a little small squirt of about 0.25 to 0.5 cc's from one side, quickly go to the other side, squirt a little bit on the other side. By the time you come back to this side, the lumen is completely anesthetized. After that, you do your probing. Assuming you have a decent punctum dilatation, everything that you do endoluminally up to the point of obstruction is completely pain-free. And you can push it a little further to try to get for recanalization as well.
Thank you. procedure is endoluminal dacrocysterninostomy.
Endoluminal lacrimal duct recanalization, ELDR.
Lacrimal duct recanalization.
And it can be done either with or without a dacroendoscope, but that is becoming a big procedure in our lacrimal clinics. Dr. Victor Ko has been very supportive of the procedures. We are now doing recanalizations that has dramatically dropped the indication for conventional DCR.